Rene, let's switch gears now. And I think as Jeff nicely pointed out before, when we think about immunotherapy, we probably think pretty evenly about across our patient population, regardless of their mutation status, BRAF mutation present or absent. But sinking in on BRAF-mutant metastatic melanoma, that's where our treatment decision-making algorithm, I think, becomes most sort of pressured in terms of, how do we pick the right therapy for the right patient? How far do we go with certain treatments before, switching when we have potentially multiple lines of therapy? I think it even raises an interesting point about PD-1 monotherapy versus PD-1 CTLA-4 combo therapy. Is compressing that regimen something that makes sense to do in a BRAF mutant population, because that way you get to next line of therapy if you need to without very much in the way of disease progression and loss of efficacy. So I'm interested in your thoughts now in thinking between kind of the high disease burden, low disease burden end of the spectrum. Where does BRAF inhibitor-based therapy fit?
I think there's definitely a role for that. I mean, those drugs are spectacular. There's no other treatment, I think, that you can give a pill to a patient and within hours sometimes they already feel that the drug is working. So when you need that kind of response, those are, if the patient has a mutation, I think that's the way to go. Just to clarify for the audience too that may not do this that often, I think I know what when you say BRAF inhibitors there, you mean BRAF and MEK.
Yeah, I wanted to get into that, but why don't you go ahead and throw that out there now, because I think that's, I think people, have been used to the idea that BRAF inhibitor monotherapy was, a standard, now there's this new evidence with combo therapy. So in your mind, is that it's simple?
That's simple. There's no, I can barely think of a role for when a patient would receive just BRAF or MEK inhibitor alone.
Right. So Rene, as you commented, the data is pretty compelling for BRAF-MEK combination therapy. On the back of these recent randomized trials, can you just kind of walk the viewers through the design of those trials, kind of what they were set up to try to address?
Yeah. So there were 3 studies: Combi V, Combi D, and COBRIM. The Combi D was comparing the trametinib and dabrafenib combination to either vemurafenib in Combi V or dabrafenib, a single-agent BRAF inhibitor in Combi D. And the COBRIM was comparing vemurafenib and
cobimetinib.
Vemurafenib was comparing vemurafenib and cobimetinib to single-agent vemurafenib. All 3 of those studies were positive in the sense that it's, without a doubt, showed that combination therapy is better than single-agent BRAF inhibitor. The overall survival is in the range of 2 years. The combination progression-free survival is 11 to 12 months, and which is better than single-agent BRAF inhibitor. So they are the new standard of care in terms of targeted agents for melanoma. Right. And there's 2 combination regimens out there, one more recently approved, and I think they're fairly similar. They have the rapid responses. The toxicities are probably the distinguishing feature that may guide you towards one versus another. Just to put it out there, the Roche Genentech combination, vemurafenib and cobimetinib, has more phototoxicity. Yeah. And the trametinib and dabrafenib combination has problems with fever primarily, and either one of them can be problematic. So you start with one. If that doesn't work, then I guess you could switch to the other one. Yeah, they're both manageable, but some patients will have it will be a limiting thing. Yeah, I think the other point that you brought up is in terms of selecting the patients. So you've got that kind of patient that needs the response yesterday. Right. And I think a harder group is the ones that have just a little bit of tumor, not a high LDH. Sure. Those patients will almost certainly respond to this, and they may be the ones that possibly get the longest benefit from it. There are tails to these curves too. They're not as far out. Right. but they're there. So I think that group becomes harder because those have also traditionally been considered the best ones for immunotherapy.
Absolutely.
And it's not totally clear to me. And the other thing that I find the most difficult is when I've started a BRAF and MEK combination on a patient and he's had a great response, when do I switch him? Yeah. Do I switch him to IPI, PD-1 combo, something,
Sure.
immunotherapy in the hopes of getting that durable remission? And that is tricky to do.
Do you do that, Rene?
I've started doing it. I've actually missed the boat on a couple of patients where I was thinking about it, talked to them about it, but they're feeling great on the BRAF-MEK combination.
Right.
And so maybe next cycle we'll do it, and then they get a brain met, or then or the tumor starts growing quickly, and then I don't have time.
Yeah.
So I think that's a situation where we need a biomarker, BRAF in the blood, something to tell us this patient's not responding anymore. You better start switching.
Yeah.
Right now we're flying by the seat of our pants.
Yeah. And just going to this, this issue of wanting to get the therapies to patients when they have the lowest disease burden, being true for targeted therapy and immune therapy. Jason.